We talked off the top of the show today about something we hadn't actually talked about for a while because the numbers certainly weren't there to talk about, and it has to do with COVID and the fact that obviously there have been fewer PCR tests now done. That's by the government's decree, by the way, not that people stop going. You may remember, if we go back, I guess a couple of months now,
at least.
we were all going for PCR tests when we were worried about this kind of stuff, and the system basically became overwhelmed, at which point the government said, look, we'll let you know who should go for PCR testing and everybody else. Get a rapid test or an antigen test. If it turns positive, if you get that kind of a test, we'll take it from there. Now we're finding out that I guess either the directive has changed or more people are getting PCR tested, and the numbers have started going up. And I mean up. We now have, over 3,000 cases now in the past 24 hours?
367 new PCR.
3,067, right? And also seeing hospitalizations go up as well. So, look, we know that the public health director, the interim director, Dr. Luc Boileau, has held off on suggesting we're yet officially in a sixth wave, but the numbers certainly all point to that. Dr. Matthew OUGHTON is a physician in the Division of Infectious Diseases at the Jewish General Hospital. He's on the line with us right now. Dr. OUGHTON, thanks for your time this afternoon. Are we over sort of stating the case here when we're looking at numbers like 3,000 again and an infection rate of over 17% to suggest it's getting bad again?
No, you're not overstating it. In fact, those numbers, as you were leading up to, implying those numbers probably are greatly understating the case. And that's because, as you very correctly pointed out, unfortunately, those PCR tests that are very restricted right now in terms of who can get them, those were our way of getting accurate, rapid, early indicators of disease in people and therefore in communities. And since I think it was the restrictions kicked in, I believe, in January, if I'm not mistaken, ever since then, those numbers have become very unreliable. To give you an idea, just in the last week or so, in Ontario, where they have similar restrictions on their PCR tests, there have been estimates based on comparing the PCR test results to wastewater screening, which is another early indicator at a population level of disease, that they may be only counting about 1 in every 10 actual cases when they're relying on the PCR test right now. So in other words, the numbers in Ontario might be 10 times as high, and I would not be surprised if we have a similar scenario right now here in Quebec.
So why not declare that it is a sixth wave? Is there some criteria that's not being met?
It's an excellent question. It reminds me a lot of the early stages of this pandemic back in February of 2020, when the WHO was holding off on declaring a pandemic, and yet there were already many indicators pointing to that exactly. And after another month, the WHO did come around, and I believe during the Sunday press conference, Dr. Boileau said that he was waiting for further advice from some of the government's scientific advisors to officially declare if this was a wave. Part of this might be an issue of semantics, because with the relaxation of some of the preventative measures, such as requirement of vaccine mandates and soon even requirement of mask mandates, there's expected to be an increase in cases once you remove those kinds of restrictions. But the question is whether this current increase is entirely explicable by that or by the more transmissible BA2 that we know for sure is here in the province and is very likely the dominant cause of new cases. And that's even more infectious on an individual basis than BA1 was that drove all of those cases that we saw here back in December and January.
So you can understand, and I'm sure being on the front lines, you deal with this all the time, BA1, BA2, Omicron, Delta, bad enough we have this pandemic. Now you got to figure out what the different variants are. So what are you seeing from this variant that you weren't necessarily seeing from the previous one? Is it about, because we heard, for example, yesterday, gastro seems to be something that kids come down in school now. Now, typically that might happen at this time of the year anyway, but maybe it's tied to COVID. Are there different symptoms you're seeing now with people who end up having COVID?
Overall, for the most part, not really. There are a couple of question marks, perhaps with BA1 and again with BA2, the overall rate of people developing anosmia, the lack of smell or the lack of taste might be less with this than with previous variants. You're correct that perhaps the incidence of some of the gastrointestinal side effects, stomach pains, diarrhea and so forth, might be a little bit higher. Sore throat also seems to be another one that, if anything, seems to be more prevalent than with previous waves. But by and large, people still have the same kind of what I think of as the core symptoms: fever, fatigue, cough, malaise. Those are the indicators of lots of different respiratory viral infections, including SARS-CoV-2, no matter what variant you're infected with.
So, Dr. Oughton, then I kind of feel that it doesn't even matter necessarily if you have Delta or if you have BA2 or any of the variants. Does it matter?
Oh, that's complicated. It does and it doesn't.
Okay.
There's at least two different reasons why it does. One is that some of the treatments that we use, if we're trying to prevent early mild infection from becoming more severe infection, are based on parts of the virus that change between variants, particularly the spike protein. So we have, for example, some of our intravenous antibody treatments that really need the spike protein to be shaped in a particular way to be at the most effective. And those treatments probably don't work as well against BA2 because of how different its spike protein is. So, in fact, knowing what variant or variants are out there and circulating actually will change your therapy. And similarly with immunity as well, it appears that BA1 and maybe with BA2, it's still early to say that the amount of immunity that natural infection gives you that applies to other variants appears to be less with BA1 and maybe with BA2 compared to earlier variants. So in other words, even if you had the infection, you can't count on that to provide sort of widespread, long-lasting immunity. We really should be sticking with the immunity that's generated by the approved vaccines.
Okay, well, that's troubling.
Yeah, it is troubling. What are you seeing at the Jewish General right now, and are you worried?
I'm concerned overall for a few reasons. I really think that this is going to I think this is going to get worse before it gets better. How much worse, that's a whole separate question, and there are already projections out from ENES that talk about this. That talk about how we're expecting to see increased numbers of hospitalizations in the next few weeks to come. Not so much with ICU cases, but we're talking about a system that has not exactly had a time to kick back and relax. We've just barely recovered from BA1 Omicron surges in December and January. We still have, as Dr. Boileau pointed out, over 8,000 healthcare workers at the present moment who are off work because of either symptoms or because of isolation requirements. And, that obviously impacts almost doubly on the healthcare system, both with losing the healthcare worker as well as having that person become a potential patient. So there's lots of reasons to be concerned. And I certainly would add that I really think under the current context that getting rid of the mask mandate on April 15th, which has been announced and so far has not yet been officially rescinded, I really think fixing removal of effective precautions when we're going into a period of increased disease activity is not well advised. Viruses don't read calendars. You need to base those decisions on real-time, reliable epidemiologic data, not on arbitrary calendar dates, because that's not how viruses work.
So by saying that, you're suggesting that April 15th data, given the data we have now and this disease continuing to spread, that's unrealistic?
I don't know if I'd couch it in quite those terms, but I think that if we have lots of disease, especially when we're not even sure exactly how much disease there is, but appears to be consistently increasing, that's not the time to get rid of one of the most widely usable, easily implementable, and effective preventative measures that we have, i.e. masking. I think we should be keeping that until such time as we know that things are settling down, not when we're going into the middle of something bad.
Well, one last thing just to ask you. Yesterday we reported that the FDA in the U.S. is now authorizing that fourth or the second booster shot, so that would be your fourth vaccine shot, for people over the age of 50. I think in Quebec we're still at 80. Mm-hmm. Why the discrepancy here, do you think? Or and should we be worried about this given the fact that it's spreading as rapidly as it is?
That's an interesting question. There's and in fact, this question of fourth doses has been around for at least a few months. Some of your listeners might recall that there was very early efforts by Israel to do a widespread fourth dose, and ultimately they found that overall it didn't appear to add a lot on a population level to widespread protection. Don't get me wrong. Under certain circumstances, people who we know are not going to mount strong responses to the vaccines because, for example, they're very old or they have underlying health problems that impair their immune systems. They're on medicines that work by impairing their immune systems. All of those circumstances, those are the kinds of circumstances under Quebec policies right now, they would qualify for a fourth dose. That, to me, makes a certain degree of sense. I'm not sure that there is strong data to support widespread availability of a fourth dose. I think if and when that comes, it's probably going to have to be with a booster that is more closely matched to the current circulating variants, right? Remember that the vaccines that have been approved and that we're still using now are based on the original Wuhan isolate, which now goes back to 2 years. That's a lot of water under the bridge when it comes to a virus that changes as quickly as SARS-CoV-2 does.
Indeed.
Okay, interesting. Dr. OUGHTON, thank you so much. As I said, very much appreciate your time. Hope we can call you again soon.
I certainly hope so, too. Thank you so much for having me on.
You bet. Dr. Matthew OUGHTON over at the Division of Infectious Diseases at the Jewish. I hadn't thought of that. And the part where he said about, that natural immunity, if you've already had COVID, and so many people already have, we're now beginning to find out. I think he said this, right? That it does begin to wane as well.
Yep. Limited.
So,
it's the virus is evolving.
Yeah.